All right. Hey, good afternoon.
Good afternoon. How are you?
I'm doing good. So my name's Adam Alderson. I'm a student here at Trinity Christian College. I was a transfer from NIU and Prairie State. I've It's pretty much been 10 years in between those two schools that I've been, but I'm studying exercise science, and I have a minor in psychology and a minor in general sciences. And today I'm going to talk to you about bipolar type 2 disorder. So if you don't mind, you can introduce yourself.
My name is Dr. Derrick Hassert. I'm a professor of psychology at Trinity, and I have been here at Trinity for the past 21 years. I teach courses primarily in neuroscience, psychopharmacology, and in the graduate counseling program, I teach courses in treatment planning and professional ethics.
Very cool. Very cool. So, how did you settle on the field of psychology, Professor Hassert?
I'm going to say I kind of wandered into it based off of my interest in psychology in general. Um, I've always been fascinated by the mind. I've always been fascinated by the brain. I was also drawn into psychology from reading literature and watching films that had psychopathology as a core component. One of the first films that stands out in my mind uh, from when I was younger is the movie Psycho, which was directed by Alfred Hitchcock, uh, which is focused on the character of Norman Bates, who had what at the time was called multiple personality disorder and what is now called dissociative identity disorder.
Mm-hmm.
And literature of that sort too, fiction literature that dealt with bipolar disorder or schizophrenia or multiple personality disorder, I always found fascinating.
Very cool. I was wondering because you said you were interested in movies about with that type of topic in mind. Did you ever see the movie Cape Fear?
Yes, yes.
That movie scared me when I was a kid.
Yeah.
Because I don't know, I've always been more scared of like the horror films that could happen in real life.
Mm-hmm.
So
Yeah.
did you feel like that was credible in that
Cape Fear.
it was with
Yeah,
Nick Nolte
yes,
and
yes.
Robert De Niro.
Yes, there have been situations where people have engaged in that sort of behavior. Uh, Within that film, there's a character who's very threatening, who was released from prison
Yeah.
and terrorizes a family. Uh, and as you said, those sorts of things can happen
Yeah.
in real life, which makes them a bit more frightening than movies where the scary aspects are a bit more fantastic,
Yeah.
like Freddy Krueger.
Yeah, supernatural.
Yeah, supernatural.
Cool. Yeah, so I appreciate that that your introduction you kind of broke some stereotypes about psychology. People interested in psychology that they're just all the research they're doing is research.
Mhm.
You know, they researching their own issues and things like that. It's
Yeah,
like
yeah.
you can have a genuine curiosity just about the mind and what makes people tick, whether that be in a good way or in a bad way.
Yeah.
So I appreciate you breaking that stereotype. Um, do you have any experience with bipolar type 2 disorder?
I'm going to say I have more limited experience with both bipolar 1 and bipolar 2. I've had maybe about half a dozen patients over the years that I've worked with who've had bipolar disorder. And I've had friends who've had bipolar disorder as well. And it's a pretty, I'm going to say, it's a pretty scary disorder to have. It's one of the two disorders that I believe, for its proper treatment, generally requires pharmaceutical intervention. So even though I've had limited clinical experience with patients with bipolar disorder, I've read quite a bit about it, and as well as schizophrenia. Again, those are the two disorders that I think require pharmacological treatment for the patient to have any significant alleviation of their symptoms. And bipolar and schizophrenia are disorders that tend to have a strong genetic component. At least the concordance studies suggest that there's a strong genetic component, as there is with depression and anxiety as well. However, depression and anxiety can often be addressed through non-pharmacological means. Psychotherapy of different types can be very helpful for depression and anxiety alone, but with manic depression, which was the old name for bipolar disorder,
Yeah.
mood stabilizers are generally required.
Okay. Yeah, well, I was actually watching a movie in Professor Guzman's class, his psychopathology class, about depression.
Mm.
And it was saying how, like, for mild depression, generally you can use psychotherapy
Yeah.
or some I forget what the word is.
Non-pharmacological or
Yeah, you can say that, or invasive like procedure to
yeah.
cure it, and then or not even cure, because we don't use that word right in
Right,
science,
right, yeah.
but like just to treat it.
Right. Effective treatment.
Yeah, but severe depression does usually require some type of pharmacological,
Yeah.
and it only works in like maybe 20%.
Right. It is not a magic bullet, because the drugs that are used, whether they affect the serotonergic system or the noradrenergic system or the dopamine system, they don't go to specialized specific spots in the brain. They're going to go to the whole brain. They're also going to go to the body, so they can cause side effects as well. And in saying that, I'm not denigrating their use or saying that they shouldn't be used. It's just that they don't have the same effect in everyone, and there are strong psychological factors that can influence the effectiveness of the medications too. Just the person, as you probably talked about in your class.
Like a placebo.
Exactly, placebo and nocebo effects can be very powerful in impacting how the person responds to the medication. The relationship between the patient and their psychiatrist can impact.
Can you clarify the nocebo for people?
Yes, the nocebo effect in a very, I guess, clear way is the opposite of the placebo effect. Placebo means to please in Latin, and nocebo means to cause harm. So if somebody believes that the drug is going to be harmful, or that the person who is prescribing it doesn't have the best interests of the patient, that can actually affect how the patient responds to the drug.
Oh wow! So it's kind of like the stress or cortisol, whatever it's affecting, like how the drug should work.
Mm-hmm.
You know.
There can be positive expectancy effects and negative expectancy effects.
Okay,
drug.
That's good to know. It's like more psychology, even when you're trying to make it biological.
Exactly.
So that actually makes me think, before I look at my thing again. So like, how much would you think that disorder, like mental health problems like bipolar disorder, are misdiagnosed by people? You know, like, you say that it generally requires, if someone really has it,
Yeah.
it probably requires some type of pharmacological treatment.
Yeah, they should be treated by a psychiatrist.
And there's people like anyone, like a teenager who's depressed or acting out in some way, and then people jump right to like, oh, he has this person. I mean, even myself, like I felt like, oh, maybe I have bipolar at some point, maybe it's type 2, but I never needed treatment.
Right.
And I felt like most of it required just introspection and a lot of like developing a strong sense of like what reality is and what reality isn't.
Yeah.
I don't know, is that more cognitive behavioral type style?
Well, as you were saying that, my mind went to a little excerpt from this book, which is by Dr. Alan Francis, entitled The Essentials of Psychiatric Diagnosis. And this book was written and released in 2013.
Oh yeah, that's when that's when I went to NIU originally as a psychology major.
Yeah, and even though this book is about 10 years old, I think it still makes some very good points, because it came out right when the DSM-5 came out.
Mm-hmm.
And he mentions that the rate of diagnosis for childhood bipolar disorders has increased 40-fold in the last 20 years,
mm-hmm.
with consequent massive overuse of antipsychotic and mood stabilizing medications. he mentions that the problems with this diagnosis rest in the boundaries of childhood bipolar disorders, being pushed into unfamiliar territory to label children who have previously received other diagnoses such as ADHD, conduct disorder, oppositional defiant disorder, or anxiety disorders. The more specific cause of irritability might be missed because with manic symptoms, it's not always euphoria. You may have talked about, maybe it's a good idea to introduce it here, that bipolar disorder is characterized by alterations between depressive mood states, and that depressive state has to last 2 weeks. There has to be a depressive episode.
Yeah, there has to be like a time limit. They said in the class, he said like type 2 is like 4 days, and then like type 1 is at least a week.
For the manic or for the depressive?
I think it was for the manic.
Yes, yeah.
Yes.
But in both type 1 and type 2, you still need a full depressive episode. Yeah.
To go with it.
Yeah. But when you go into a manic phase, the stereotype of a manic phase is having a lot of energy and self-confidence and embarking on several different tasks all at once, sometimes being in a euphoric mood.
Yeah.
But it can also be characterized by anger and irritability, which you see quite often in adolescence, anger and irritability. So what Dr. Francis is saying is that perhaps by giving the diagnosis of bipolar to an adolescent or a child, it's missing what might be an underlying precipitating factor in the child's life.
There you go. Yeah, that makes me really think. So like, not only is it misdiagnosing in general, but you know, it's like people say don't self-diagnose, get a real diagnosis. But now we know that even getting an actual diagnosis could be bad too.
Yeah.
You know, if people are going off of more recent criteria that may or may not be stress tested, I guess.
Right. Yeah, there can be issues with using diagnostic criteria because the clinicians can be wrong. That's true. I will say though that I don't think that that is a reason for completely doing away with diagnostic criteria.
Of course.
Or diagnoses in psychiatry.
Yeah.
I think they're necessary. I think we see these things popping up enough, and once you see schizophrenia once, you see it again, you know that that's schizophrenia. You have an idea, that's something I've seen before. The human mind goes towards labeling and names. When we see patterns, we like to give a name to what it is we're seeing repeatedly.
There's a reason we have doctors, essentially. You know, you can't do it with doctors.
Yeah.
All right. What would you say the etiology or the origin of bipolar type 2 disorder is?
I think...
In fact, before we do that, actually,
Sure.
How would you make the distinction between bipolar 1 and bipolar 2 before we get into that? Sorry.
It's difficult because when we say bipolar 2, the differing criteria for bipolar 1 and bipolar 2 is that in bipolar 2, the patient suffers from not mania, but what's called hypomania, which simply means less than mania.
Yeah.
And that's something else that Dr. Francis mentions when making the distinction between bipolar 1 and bipolar 2. The word hypomanic is just a fancy way of saying less than manic. A hypomanic episode is indeed less severe than manic episode, but it has the same symptoms. It could be elevated mood, expansive self-confidence, increased energy, intrusive sociability, and less need for sleep and rest. The mood swing has to be a distinct shift upward from the person's usual way of functioning. The unique thing about a hypomanic episode is that it usually does not by itself cause clinically significant impairment or distress.
Yeah. And
sometimes it might not even be distinguishable from somebody just having a good day or a good couple of weeks. Yeah. But then it alternates with a depressive episode. The depressive episode is the kind of common uniting factor there between bipolar 1 and bipolar 2. But the hypomanic phase can be shorter, as you pointed out, and it's generally less pronounced, and it generally does not cause the patient distress. They might actually seem more sociable and more active to other people, but maybe not in a way that would strike other people as being out of the ordinary from other individuals in the environment. Whereas a manic episode, the person is going to present as a bit odd in terms of the amount of energy they have, and in terms of the amount of, let's say, emotion that they're showing. I knew someone who had bipolar disorder and would go around hugging people and like expressing how much that she loved all the people in her life in ways that seemed out of character for her.
So she was normally like not as huggy?
Not as huggy a person.
Oh, okay.
Not as effusive in her socializing or sociability. And I like the word here that Dr. Francis used, intrusive sociability.
Yeah.
Somebody just walks up to you and starts talking to you and a mile a minute and hugging you and expressing how much they care about you and they love you.
That's actually a nice trait, I guess, to look out for. Like, I never thought of it that way before. Because one thing that Professor Guzman taught us in class was that, like, you said clinical severity.
Yeah.
And then, like, he kind of said it in the DSM-5. He used that in his PowerPoint slides as, like, one's going to require hospitalization and one's probably not. Like bipolar type 1 usually requires just like hallucinations and hospitalization.
Yeah, it can be that severe that there are elements of psychosis along with it.
Gotcha. So now we can, I guess, move on to that third question. The third main question is the origin of bipolar.
The origin of it. Yeah.
Yeah. So what do you think the origin of it is?
For schizophrenia and for bipolar disorder, I think, again, this is mostly speculation. The studies are suggestive but not conclusive that there's a biochemical imbalance in the brain of individuals with bipolar disorder, but all of the different neurotransmitter systems have been implicated in it. I'm going to quote from this book by Craighead and Milkowitz and Craighead, Psychopathology, History, Diagnosis, and Empirical Foundations. Substantial evidence now suggests that bipolar disorder is related to diminished function of the serotonin system. As serotonin constrains other neurotransmitter systems, deficits in the function of the serotonin system are believed to allow for greater variability in the function of dopamine, and dopamine is the feel-good chemical in the brain. It responds to reinforcement or the expectation of reinforcement. Neuroimaging studies indicate that mood disorders are generally associated with decreased sensitivity of the serotonin receptors. Research on unipolar disorder has examined how people respond to fluctuations in serotonin, induced either by depleting or augmenting of tryptophan, the precursor to serotonin. Persons with a positive history of bipolar disorder display more cognitive deficits after serotonin depletion and serotonin augmentation procedures than persons with a positive family history. Without a positive family history with the diagnosis. Serotonin used to be viewed as a chemical that made us feel good. But as pointed out here, serotonin both with depression, unipolar depression and bipolar depression, is probably a chemical that helps to regulate or inhibit and coordinate the responses of other neurotransmitter systems. So dopamine's probably involved, glutamate's probably involved, serotonin's probably involved. Gamma aminobutyric acid is probably involved as well. The cyclic nature of both bipolar 1 and bipolar 2 has long suggested that there's something going on endogenously, internally, that is related to the changes in mood, that it's it's not just a reaction to something in the environment. Although with depression, with the depressive aspects, cognitive behavioral therapy can be helpful because uh, challenging beliefs or challenging the emotions and the significance of the emotions can still be helpful therapeutically. But in terms of trying to regulate the shifts between depression and mania, that's where a drug that functions as a mood stabilizer is probably necessary.
Is there any difference in how these chemical reactions happen between like bipolar 1, bipolar 2? Is there like a distinction in them that researchers are aware of?
I don't, to my knowledge, and I am not completely up to date on the literature, but to my knowledge, they haven't been able to like tease apart that fine-grained of a distinction in the neurobiology between bipolar 1 and bipolar 2.
Okay, it's just different, for whatever reason, different levels of severity in these two people.
Yeah.
Okay.
Some people with bipolar 2 do develop later on at some point. There's 1 in 10 will wind up developing bipolar 1.
Gotcha. So it kind of like progresses.
Yeah.
Okay. How do you, well, since you brought up I guess maybe some of the neurotransmitters involved, like, what do you say about the people who say that, well, the chemical imbalance in the brain is a myth these days?
I think,
or is that it's just an oversimplification?
I think it's an oversimplification. As you mentioned and as we talked about, the drugs don't work for everyone.
Mm-hmm.
It doesn't mean that there's not something wrong or going on in the brain. We have between 80 and 100 billion neurons in the brain, and they're balanced in a very fine-tuned way with neurotransmitters and connections, and we're putting drugs in there that affects the entire brain for the most part. So, and I'm not saying that the neuropharmacology is going to at some point solve everything.
Mm-hmm.
It might not. It probably won't, especially not for things like anxiety and depression, which are so pervasive in terms of our responding to the environment.
There's no way everyone, like you said, there's no way there's a magic bullet that's going to help everyone.
Yeah.
On something that massive.
Yes. So it is to a certain degree true that the idea that depression is caused by too little serotonin, and that if you just give the right antidepressants, people are going to be happy. That hasn't worked. We've had the SSRIs, the serotonergic reuptake inhibitors, for decades now, since the 90s, and the rates of depression are still pretty much the same as they were in the 90s, and maybe even higher. So we don't know exactly what is broken with the brain of somebody suffering from bipolar disorder, but we do know that the drugs do help with a chunk of the patients, not all of them, but some of them. And as with schizophrenia, I think the medication should be tried to see if it helps. If it can help the patient be more adaptive in their functioning, I think it should be utilized.
Yeah, like I think we said before, like help them calm down so that they can be more responsive to treatment.
Mm-hmm.
That's pretty much the primary use of medication, I believe.
Psychiatric, yeah. Yes, with psychiatric medication, even with schizophrenia, changes in social supports and the structure of the patient's life can be very helpful too. And with bipolar disorder, there's a good book that came out many years ago written by, I want to say it was Judith Beck. I could be wrong on that, but it was Cognitive Behavioral Treatment of Bipolar Disorder. And they reviewed all of the research about how the patient can utilize structure, can utilize predictability, good activity hygiene and sleep hygiene to minimize the risk of severe shifts into the manic states.
I see. So it's like you said, structure, having an ordered life,
Yeah.
kind of keeps their internal life in order.
Mhm,
In a sense,
mhm.
in a sense.
Yeah.
That's pretty cool. I think I heard something like that before. You know, so that makes me also think about. So you brought up a question of mine for me when you said that the rates of depression have kind of been similar
Mhm.
in the '90s to, and they maybe even increased
Yeah,
today.
yeah.
And just the change in our society with like
Right.
phones and social
Right.
media, and people
Right.
are maybe less communicative. Is that the right word? Or
Communicative,
yeah,
communal.
yeah,
We're more connected, but we're more alone.
yeah,
We're more connected electronically, but that has not helped our emotional and mental health.
right.
In fact, it seems most of the research suggests that it has made us more anxious and more depressed.
So, do you think a lot of the solutions may not be reductionistic, as in this medication or this chemical is going to help, or more holistic, like a change in the culture as a whole?
Yeah,
Would probably be a lot more effective.
It would be more effective and also harder to achieve,
Yeah,
given that we all seem very much addicted to our electronic devices.
yeah. It does make me think about like how epigenetics could
Mhm.
have a role in that. You know,
Yeah.
how the culture influences the transmission of
Mhm.
genetic information to the next generation. Not
Yeah.
necessarily Darwinian,
Right.
but just like
Right. And or at a basic level, what genes are being activated by the constant barrage of reinforcement that we get from electronics.
oh yeah, I didn't think about that.
Yeah. Which
Good.
in the past we would only get through actual interactions with other people.
I fear that we're gonna have to, you know, look. We have to get through all the conspiracy theories, involved with that type of, those thoughts, because
Yeah.
people jump straight to like your phone's giving you cancer in the brain or something, you know. It's just like, I don't know if it's that bad, but
Even if it's not giving us cancer, it's it's making us less happy
yeah,
and more anxious.
there we go. Before we move on to something else, I kind of want to clarify what does GABA do?
GABA is the primary inhibitory amino acid neurotransmitter in the brain, gamma aminobutyric acid. Uh, and actually, really, there are only two main neurotransmitters in the brain. Most of your brain is a delicate balance between glutamate, which is excitatory, and GABA, which is inhibitory. If we were to do a pie chart of all of the neurotransmitters in the brain, most of it on one side would be GABA, and on the other side would be glutamate, and then a little slice of the pie would be all of the other neurotransmitters that we talk about,
Yeah.
like serotonin and acetylcholine and dopamine.
Okay.
So, as an example, if you drink alcohol, it turns on your GABA receptors, which are responsible for turning things off.
Which is why it's a depressive.
Right,
It kind
right.
of slows you down, turns you
Exactly.
off. Okay.
Exactly. And when we say depressant, it doesn't mean makes us feel depressed, it means shuts things off.
Oh, I see. That's why you fall asleep after drinking
Exactly,
too
yeah.
much.
Right.
Got it.
And before you fall asleep and pass out, you can have blackouts, which means you're still behaving, but the memory part of your brain has been suppressed and turned off, so it's not recording things.
Oh wow. Yeah. I don't want to give myself away.
Okay.
That'd be pretty funny though.
Understood.
There was one other chemical I was interested. So you said you also mentioned tryptophan as a precursor to serotonin.
Yeah, yeah.
I always thought tryptophan, like I heard that like when you eat turkey at Thanksgiving,
right.
you get tryptophan,
Right.
makes you sleepy.
It's also the precursor to melatonin, which helps you sleep. Yes.
No, okay. How does that affect the bipolar? It's just because it is a part of serotonin.
Right.
Okay, got it. Okay. Number 4. What are their main symptoms? Did we go over that with bipolar? The main symptoms.
A little bit, but let me just mention that with bipolar disorder, as you said, as I think we both commented on, you need to have a depressive episode.
Mm-hmm.
And the depressive episodes are generally 2 weeks in length.
Yeah.
The manic episode, and we kind of went through the symptoms of the manic episode, the elevated mood, the intrusive sociability, less need for sleep, things like that. For a full-blown manic episode, that's about a week long, and for a hypomanic episode, it might be less. Could be the same length, but the symptom severity is going to be quite a bit less, to the point where it might not even look like anything's wrong with the person. As we said, they're having a good few days.
Yeah. Like you said, in your example, there was someone you knew who was like really huggy.
Yeah.
You know,
Yeah.
and then like, what would that look like as a manic episode, or not manic, but hypomanic?
Right.
Would that
Exactly.
just be like, you just go around shaking hands instead?
Perhaps, or just saying how much she missed people.
Okay.
Yeah, the more pronounced symptoms would be like being very talkative, hyperactive, or perhaps irritable or distractible. But yeah, with what would be considered a full-blown manic episode, it would be much more pronounced.
Okay. Okay. I want to ask you another question before I ask you that. Is there I forgot what I was gonna say. Triggers. So, are there any particular triggers for both depression and mania, or that are specific to bipolar?
One of the main triggers is changes in daily structure, and within that, disruption of the sleep cycle can be a powerful trigger for a manic episode. Meaning, let's say it's 10 o'clock at night, usually go to sleep at 10:30, but you feel like, I don't need any sleep.
Yeah.
So you decide, I don't feel tired, I'm not going to go to sleep.
Right.
You stay up all night. That can often be the pathway to a period of mania, a manic episode.
Yeah, so you make it worse.
Right.
Because you feel good.
Yeah. So maintaining good sleep hygiene is very important.
We were talking about in class how like substances like marijuana can also be a trigger.
Yes, and given the greater prevalence of marijuana because of legalization, that's a concern for both schizophrenia as well as bipolar disorder.
Okay. How are we looking on time? Do you have a lot of time?
I think we're close to maybe half an hour.
Oh, okay. Maybe I'll try to wrap this up, I guess. I don't know. I kind of like talking about it. If it's not bothering you, are you busy after this?
I've got an appointment at 1, but
okay, I'll hurry up. Okay. So I want to ask you one last question about bipolar and the symptoms and everything. So, could you clarify any distinction between? So you said there's not much of a distinction between 1 and 2 besides the severity and length of maybe the symptoms. What about other various forms of bipolar? Are there other various forms of bipolar, like cyclothymic disorder, or the bipolar depressive disorder?
Right.
I think that was
Right.
one.
Yes, if you have, let's say, mild ups and downs for mood that have lasted for about 2 years, but they seem to be a bit fuzzier, blurrier than bipolar disorder, then that would be cyclothymic.
How do you
disorder.
determine fuzzy or blurry? It's just
Well, thankfully I have right here a little flow chart from a book by James Morrison, a psychiatrist, called Diagnosis Made Easier. And that would be a good book if you're interested in diagnostic criteria to have.
sure.
So here's a list of the symptoms, and this is the flow chart that winds up going to cyclothymia. Manic symptoms less severe, hypomania. Never hospitalized or psychotic. If you answer yes, is there a history of major depression? The answer to that is yes, consider bipolar 2 disorder. If the answer is no, there's no history of major depression, but only mild ups and downs of mood for 2 years or longer, then you would consider cyclothymia. If there are no ups and downs, ask, does the mood disorder cause clinical distress or impair social, personal, or job functioning? If the answer to that is yes, consider unspecified bipolar disorder.
Mm.
And that is something that is in the DSM, unspecified, because it doesn't fit quite as well, but it seems like, it feels like it still is a bipolar disorder. If the mood changes do not cause significant clinical distress or impairment of personal or job functioning, then consider no mental disorder. So, you know, is it ups and downs, but the ups and downs don't seem to impact anything?
That seems very convoluted.
Yes, yeah.
It seems like we're back to the whole overdiagnosing issue.
Yeah.
Like, it seems so inclusive. I mean, because in class we actually talked about how overdiagnosing is a problem, but having things like the DSM-5 is actually still a good thing, because there is someone out there going through some type of problem, and it's good to have information like this available for them.
Right.
You know, as opposed to, oh, we don't really know what's wrong with you, you're just weird, you know.
Right. And that's kind of going back to some earlier points. We need the diagnostic labels as soon as we see that these characteristics are things that pop up in human experience repeatedly enough that we say, well, oh, I've seen that before.
Yeah, I see.
Then we develop a name for it.
Yeah, you want to develop something so you know it when you see it.
Exactly.
Yeah. All right, thank you. So, how would you say bipolar disorder type 2, in this case, disorder, impact the individual's development? Is there any impact on it?
I'm gonna say I'm not sure. I know bipolar disorder does impact, bipolar 1, because it generally leads to hospitalizations. That impacts people's social functioning, their occupational functioning to a very significant degree, and it can be time consuming, costly for families of those suffering, for the individuals themselves as well as for the families. Bipolar 2, because it leads to less hospitalization, less disruption, and it might not be caught, not be diagnosed as easily, it's probably going to have less of an impact, I'm going to say developmentally, from, let's say, somebody being a teenager onward. Their functioning in academics and social life is probably going to be a bit smoother than somebody who has bipolar 1.
Gotcha. Not to say that it won't affect it.
Not to say that it won't, it's probably just going to be less severe.
Got it. I think we went over that. I was going to ask, like, does the process of being manic or depressed change the brain? Do we ask that upstairs or not here?
We talked about that a little. Yes, we talked about that upstairs, but that's a debate as to whether, let's say, the disorder and the symptoms cause damage to the brain, or whether the functioning of the brain
was already damaged.
Is already not functioning properly, and that's giving rise to the symptoms.
Got it. So that, it's kind of chicken before the chicken.
Exactly, and it brings into the discussion the consideration of whether certain psychiatric disorders could be considered degenerative, meaning that the disorder is getting worse as you continue to have it.
Got it.
And they're not generally thought to be like that, even with schizophrenia. Some people have a remission of schizophrenic symptoms as they age. So it's not like Alzheimer's or Parkinson's, where it just keeps getting worse and worse.
That's interesting. Is there any idea as to why that is? Why remission would happen?
No.
Are there any protective features with aging? I hear people become more emotionally balanced as they get older.
Yes. There do seem to be, with the personality disorders as well as psychotic disorders, aging seems to lessen the severity of those disorders. But with Alzheimer's or Parkinson's, aging makes those things more likely.
Interesting. It makes me think of David Bowie quote. Maybe it's not really him, but like, you become who you were always supposed to be the older you get. So people with these problems, they aren't just problem people in of themselves. They're maturing just like everybody else and getting better. I think we went over that. Like evidence, what are evidence-based treatments we must offer? I would say it like this: what evidence-based treatments must we offer clients with this disorder? And you said pharmacological
Yeah.
for bipolar type 1.
Yeah.
And then what 2, you think just psychotherapy may be enough? Or it would probably still need some pharmacological?
Psychotherapy for milder cases of type 2 might be enough. Randomized clinical trials using psychotherapy as well as medication tend to support the idea that the psychotherapy can help stabilize and prevent recurrences. So psychotherapy can be helpful, but I don't think it can be a standalone treatment.
Is there any like new research, worth knowing about, or any novel research, or any particularly like accredited research? I guess I don't know how to say. On
the
bipolar.
treatment or on the causes. Not
on treatment.
Not to my knowledge, but I'm not completely up to the minute on the research.
Got it. Okay. What would you say to someone suffering from this disorder and their loved ones?
Seek evaluation and seek treatment. It can be helpful.
Got it. Are there any final thoughts you would like to share?
Just that bipolar disorder is probably one of the more insidious disorders psychiatrically. It can be very, very stressful on the person suffering from it. And I'm speaking here specifically more about bipolar 1. Hospitalization, increased risk of suicide. So treatment is absolutely necessary if somebody has this diagnosis.
Okay. Well, thank you for your time, Professor Hassert.
Thank you. Thank you.
Thank you, and I hope the audience enjoyed everything you had to share. I thought it was really interesting. I appreciated the references you made to some of the books you have with you. They're worth reading.
Yes, they definitely are.
Maybe if I find someone who can like timestamp them in the video, did you be able to find it more easily? All right. Thanks, everybody.